Got a very interesting case, bonding the incisal edges of the maxillary and mandibular anterior teeth. You will see this in your practice a lot. You should be able to treat it and treat it effectively. I think most people that treat this condition don't think about the dynamics of bonding maxillary and mandibular anterior teeth. This is the key concept. Number one, if you're placing bonded composite, you can't make the composite restoration any longer than the longest part of the existing tooth. See this part of the tooth right here? I can fill in these gaps, these chipped areas, but I can't make the teeth this long, or what's going to happen? They're going to break off the bonding when they grind their teeth. The other thing is you've got to protect the bonded composite. You can't just stick it on the edge of that tooth or they'll lose it within a week. You've got to make a little foxhole in the incisal edge of the tooth in the dentin to hold that composite, and then you can build it up to this edge. The other thing is the patient has to have a night guard. Unless they are just lighting their cigarettes with $100 bills and have all the money in the world and they don't care if it breaks or not, if they don't wear a night guard, they're going to fracture this composite within maybe the first night, because that's their grinding pattern. People grind their teeth at night and they use the same pattern, and this was from bruxism, nighttime bruxism. It's not from eating food. I mean, they may have broken off an edge eating food and the patient says, well, I did that biting into a marshmallow. No, no, no. You ground your teeth, rubbing them together at night like this. Get these dental books, by the way, so you can explain things to people. See how the patient rubs their teeth together and they create that little knife edge right there from rubbing them together at night when they're sleeping. When I see a new patient, it kind of freaks the patient out because I can tell them about their sleep position by how they grind their teeth. In other words, if the teeth on the right side are ground away, you know that patient sleeps on their left cheek and they kick their right jaw up. If the teeth on the left side are ground away, you know they sleep on their right cheek and they kick that jaw up to the left and they wear those teeth. If they're worn in the front, then they may sleep all over the place and they end up with teeth looking like this. You sharpen the inside edge of the lower teeth and the outside edge of the upper teeth, and the patient gets that thin knife edge on those teeth, and then they bite down on a marshmallow and they tell you, I broke that tooth eating a marshmallow. No, they broke that tooth because they had a little wire edge right here. If somebody questions the pressure someone can put on their front teeth, have them put their little finger between their front teeth and bite down as hard as they can and see how much pressure you can take. Not a lot. So when a patient's grinding their teeth, bruxing at night, they're putting maximum pressure on those teeth and they will wear them out if they don't wear a night guard. So the patient must understand these bonded composites are not like tires. They don't wear out. They break in one incident of not wearing the night guard. The night guard is like brakes on a car. It protects the investment. So why do you even fix that? Why don't you leave it like that? Well, there's a couple of reasons. Number one, it looks gnarly. It looks unkept. I mean, this guy's not going to get a date with his teeth looking like that. The other thing is, the incisal edges of the lower teeth often get dark when the patient has worn the teeth into the dentin of the tooth. And people don't like that brown look, so they want a lighter look. And whenever you have a serrated edge like this, you're more likely to catch it on the opposing teeth and break more of the tooth off. So you want a smooth edge. Before and after, you can see the incisal edges are ground into the dentin. This after the restoration. See how they're ground into the dentin here, and this looks brown and it's very unsightly. Women especially don't like that. But see how we've placed a little lighter composite in these edges, and it's smooth now so they won't catch that serrated edge on an opposing tooth and break it off. But don't be thrown off when a patient says, I broke this biting on a peanut butter sandwich. Well, that was the final straw. They'd worn those edges and sharpened them, and they were little thin, translucent edges, and they broke off that little thin edge eating that peanut butter sandwich. So first we're going to give painless and profound local anesthetic. If you can give painless and profound local anesthesia so that the patient never feels anything, they will fly in from Alaska to have you do their dental work. People are pretty petrified of having dentistry done, and it begins with a painful local anesthetic, or the dentist can't get my teeth numb. There is no excuse for not getting a tooth completely numb, and that video and the other videos on painless and profound local anesthesia teach you how to do that. Here's where we begin. You see, they've worn the teeth into the dentin of the tooth. Now, if you just place a bonded composite on that tooth as is, they're going to break it off. You've got to create a little tiny trench in this dentin to protect the bonded composite. So this is a 1/2 round burr on a high-speed handpiece, lots of water, and I'm just creating a little trench in here to protect the composite. Not deep, just maybe 1/2 millimeter to 1 millimeter deep. You create more surface area. So it's locked in, it's like the roots of a tree. It holds that composite. They still have to have a Nightguard or a dental snoring sleep apnea device. See, just a little trench, a little tiny round burr. You don't have to anesthetize the teeth to do this 99% of the time, by the way. It's not a painful thing to create that trench unless somebody just has hypersensitive teeth. Many times I'll do this procedure while I'm doing other things. I have long appointments every morning on sedated patients. I usually see one patient from 8 in the morning until 1 or 2 in the afternoon, and they're sedated for those appointments. So while they're sedated and anesthetized for other things, I can perform this procedure. So see, we've not shortened the length of the tooth. Here's the other thing. If somebody's there has a worn edge, don't ever cut that off. Just say, oh, I'll just cut that part off, because the process is going to continue, and before you know it, they've got no teeth. Don't ever shorten the tooth, bond it, but they have to have a Nightguard or a dental snoring sleep apnea device that keeps them from rubbing their teeth together, and they have to wear it every time they take a nap or sleep. Don't ever forget this. The patient has the problem. You, the dentist, do not have the problem. You're helping them correct their problem. Don't make their problem your problem. How long do I stand behind these bonded composites? Can you see these two hands? It's not just one, it's two, meaning 0. Once the patient walks out the front door, they pay for it if they break it again. If they don't see this as a problem, don't fix it. Don't fix it. The patient should view the condition you're treating as a problem. If they do, you can treat it. You should be able to treat it the best it can be treated, but you can't guarantee it. The only thing I can guarantee for a lifetime is a shot put and a flint rock. You can't break those things. A patient can break anything you put on their teeth if they try hard enough. So you're trying to help patients correct the problems that they view as a problem. Then I'm just lightly roughening, freshening the facial surface of these teeth. Not much, just barely. And that's a coarse beryl diamond, just barely freshening that surface, because I want this composite to go into the inner part of the tooth in that little foxhole of dentin I've created, and then just barely cover these incisal edges. But I'm not removing any tooth structure. Now this is isopropyl alcohol on a cotton ball. I'm just scrubbing the area that I prepared. You can see these little trenches, very shallow trenches I've cut into the incisal edges of the teeth. This is 38% phosphoric acid, and you're going to etch dentin for about 15 seconds and enamel for 45 seconds to a minute. So most of us are not going to place it on the enamel, then come back and place it in the dentin if it's a kind of a small restoration like this. So normally I'll etch for 45 seconds. Then when we remove the phosphoric acid, we remove it from the teeth that we placed it on first, and just suck it off with that aspirator. Have your assistant just suck off the volume, then go back with your air water syringe, have the patient turn their head to the side, and just rinse everything off. And I'll rinse for about 20-30 seconds. Then I'm going to take a 2x2. I'm not going to desiccate the teeth. I'm going to take a cotton 2x2 and dab the teeth so it removes the volume of water. Don't forget, the acetone carrier in the primer adhesive likes water. It's hydrophilic. Acetone is hydrophilic. It's attracted to water. So if there's a little dampness in those dentinal tubules, it pulls the acetone into the dentinal tubules, which carries the primer with it, and you get that wonderful hybrid layer. The primer sets up in those dentinal tubules, and it makes that restoration so much stronger. So it's not a real issue if you desiccate the teeth. You still get a good bond, but according to the studies, you get an even better bond if there's a little fluid, some fluid in the dentinal tubules. You get the hybrid layer. So I'm isolating the mouth. I'm not using a rubber dam. Now, if you want to use a rubber dam, that's great. I've not anesthetized these teeth, so I don't want to put a rubber dam on the tooth. That might be painful. I don't want any pain in my practice. I want patients to think of me as the painless and the best dentist in the world. I don't want to give them any pain. And if I put that clamp on that tooth and it clamps into the gingival tissue, that could be uncomfortable. It's not that it's not the best technique. It may be. But I stuff their mouth with 2x2s to isolate this from breath, and then paint the primer adhesive on the teeth, get it onto the edge. See, this is loaded with 2x2s. It's not just one. There's probably 8 2x2s in this patient's mouth. Capture any of the breath. Now, when you blow off the primer adhesive, this is a very particular technique. Don't just blow it off all over the tissue and all over the teeth. That's going to feel like hell to that patient's tongue. Put the 2x2 right on top of the primer adhesive and blow it into that 2x2 so the 2x2 captures 90% of it. Then come back and blow it off, and then floss interproximally. Be sure there's not any in the contact area. And I'm doing this before I cure the primer adhesive. Don't forget this, if it's direct composite, cure the primer adhesive before you cure the filled resin, the composite itself. Cure the primer adhesive, always cure the primer adhesive before you cure the filled resin or the composite itself. Cure them in 2 stages. The only time that's not true is when you're placing a veneer. When you're placing a veneer, cure the primer adhesive, the filled resin, all in the same cure. If you do that, you know the primer adhesive is cured really well in the dentinal tubules, and you'll never have sensitivity with the composite because those dentinal tubules are filled with something solid that's really cured well. Then come back and cure it. Now you only have to cure it about 5 seconds per tooth when you're curing primer adhesive. So we've blown off the excess, remember, so all the acetone carrier is basically gone. Because if that acetone is included in that bonded package, it can compromise the bond strength. This is flowable composite. It's Filtech Supreme by 3M. I've used it for a long time. A lot of good flowables. The thing I like about this is it polishes well, it's durable, and I've used, back in the day, I used a couple of flowable composites that had a lot of air in the tube. I don't want any air in the restoration. So to keep from getting air, you keep the tip in the composite as you flow it in that little trench. They don't take it out of there and then move it on to the facial just a little bit. Then this is a plastic instrument. Just smooth that just a hair. We're going to polish it with a Shofu disc. Same thing here. Keep the tip in the material, and then keep the tip in the material on the facial. We want to smooth these serrated edges and cover up the dark, so it's a smooth incisal edge. Then I'm going to cure each one. I'm just spot curing the first two, and then in the end I'm going to cure each one for 40 seconds. So this is just gross placement right now with some smoothing with the plastic instrument. You want to smooth from the material to the tooth. This Shofu disc is fabulous for polishing that. All right, now I think we're spot curing here again. See how I'm keeping the tip in the material. That's very important, or you'll incorporate air bubbles. And remember, you're not lengthening the teeth. The composite can't be any longer than the existing part of the tooth. It can't be any longer than that part. The teeth won't be any longer. You'll just fill in the chipped gaps. These are ways of showing patients what before and after looks like, and then when they look at photographs of their teeth, they understand what you're trying to do. So see, these teeth can't be any longer than that part of the tooth. You're just filling in those gaps. But this is like a rooted tree when you have that little trench in the dentin. It gives it some more surface area. And now I'm doing the same thing on the lower teeth, just creating that little trench and then just lightly roughening the facial surface, incisal facial, not much, just a little, so we've got more surface area there. This is something that's not a hard procedure, but patients will really appreciate it, especially women. They hate that brown edge, that brown incisal. So this is an easy way to correct that. And this is isopropyl alcohol again, just cleaning them real well. Then place the 38% phosphoric acid for about 45 seconds. Then come back and suction from where you began to do the first ones first. Then you rinse it off. Now you're placing the primer adhesive. Remember, it's got acetone carrier, so we want to blow that off. Plus, if you had a lot of primer adhesive in it, it's not filled. And so if that was taking up the space of the composite, it's not going to be as dense and strong as if you blow that off. You've got plenty of adhesion if you blow off the primer adhesive. Then I've isolated the mouth with 2x2s. There's probably 8 2x2s in there to keep the breath off the teeth, and blow it into that 2x2. Don't blow it all over the gums and the teeth. Then floss it. Be sure there's not any primer adhesive in the contact areas. Then I'm going to cure the primer adhesive before placing the filled resin. That's very important. You'll never have sensitivity, and you're sure that you've got maximum bond strength. So I always cure the primer adhesive prior to placing the filled resin when I'm doing direct composite, not when I'm placing veneers. You can watch the veneer videos. I don't cure the primer adhesive with veneers until after all the veneers are placed. So filled resin, keep the tip in the material. You won't have any air bubbles. And if this tooth was say it was an A2 shade, I'm probably going to place B1 composite, a little lighter than the teeth. It blends perfectly and makes the whole tooth look lighter. Now this is a good time before you do this or do any restorative work. I always talk to patients about bleaching. I never talk anybody into anything. But this is why in my opinion, you should do a comprehensive exam and consultation on basically every patient. You have an obligation, in my opinion, to inform the patient of their existing condition and what their treatment options are. And photography is a fantastic way to do that. But talk to a patient about bleaching their teeth before you do restorative work. Most people want their teeth as light as they can be. And so don't do restorative work on teeth that are yellow. The patient may want a lighter tooth. You're not talking them into it, you're just giving them information on treatment options. Smoothing this on the facial surface with the plastic instrument and flossing before I've cured anything except the primer adhesive. Floss after placement and blowing off the primer adhesive and after placing the filled resin. Then come back and cure 40 seconds for every 2 teeth. I'll hold the light over the 2 teeth for 40 seconds and then go on to the next 2. And this is a soft lux finishing and polishing disc. They're fabulous for this because they cut composite, but they don't cut the teeth. So I'll use this, I'll use a fine flame-shaped diamond burr, and I'll use a 12 fluted and 30 fluted carbide burr to polish these. That's all I use. I'm just sculpting. I'm taking away, making it look like teeth. You always want to, I want a little over bulk rather than under bulk. Not a lot, but a little, so I've got something to work with. And I'm going to do the gross trimming with this and the fine flame-shaped diamond, and then I'm going to come back with the number 12 and the number 30, the 12 and 30 fluted carbide burrs. Then polish on the facial. Be sure you get any excess material off the facial. These composites are very strong. See, this is the flame-shaped diamond. I'm just sculpting any of the excess material, rounding. A lot of times I'll do this with no water. It's just a light touch, or I may use just a little water. Just rounding, step back in front of the patient and look at it and see how everything lines up. Remember, you're not trying to make these teeth all the same length. I want to be sure you get that point. The patients ground them off like this. If the patient wants to make them the same length, veneers. You can do it with veneers because they're strong enough. Veneers in a Nightguard or a dental sleep apnea snoring device. With composite, you're not making them any longer than what they were. You're just filling in the chipped areas and getting rid of the brown dentin. So squirt that water when this is out of a water bottle, or you can use your air water syringe just as a lubrication and keep the composite that you're polishing moved away so you can see what you're doing. So this is a small chamfer diamond, fine diamond, just removing any of the excess from the palatal, and use this is a large, or what we call a skinny, occlusal mirror. I use those for everything. And just look, sometimes it's hard to look in your hand mirror because it's got such a small surface area. This has a large surface area. It's easy to keep up with what you're doing. Just contouring this so it blends in seamlessly with the palatal surface of the teeth. So it's a process. We do this and then come back with this. This is a 12 fluted carbide burr, this one. And I use that a lot just to sculpt these edges. If there's any little void somewhere, you may have to add a little bit more of that flowable composite. You don't have to etch again if you're bonding composite to composite. If you're bonding composite to two structure, you have to etch again. So once I've pretty much completed it, I come back with this Shofu rubber wheel. Now, I don't like the wheel when they first come out of the box because they've got these square edges. I like it after it's been used a while and the square edges are rounded off. And this is a nice size right here. But you may want to round those square edges off on some surface so that it's shaped like this and not square. And then it's perfect for this because it removes composite, but it doesn't remove tooth structure. So you get rid of any edges on the palate or the lingual. If there's any primer adhesive or composite on the palatal surface of the teeth, it removes that, and you know you don't have any roughness or any pointy edges for the patient to feel with their tongue. And always make them feel it with their tongue, ask them to feel it with their tongue and see if there's anything pointed or scratchy. But this is a wonderful instrument for that. You see how I lubricate it while we're using that Shofu rubber wheel. Now I'm fabricating the Nightguard. Watch our YouTube video or our dentistry video and dentistrymasterclasses.com library on how to fabricate a Nightguard. I like a Nightguard that I have to reline in the shell, in the mouth. So my assistant fabricates this shell prior to the patient coming in, and they fabricate it from a preoperative model. And you put several thicknesses of aluminum foil on the model so it doesn't fit precisely. It's just a shell, so you can add the composite and our veneers and come back and reline the Nightguard and place it at the time that you place the restoration. I don't want this patient going even a night without a Nightguard, or what could happen? They could break these off and then we have to do them again. Be sure you place Vaseline all over the incisal edges of these teeth before you place the Nightguard. This is an acrylic shell and bisacrylate in the shell with lugs cut into the side for mechanical retention. But be sure you place Vaseline on the newly placed composite incisal restorations, or this bisacrylate will stick to it and you'll have to polish it off. So push it to place, then come back with the back edge. This is not a video on how to make a Nightguard. You can see how to do that in the library of dentistrymasterclasses.com. If you're subscribed to that, all the videos are in that library. All the dental minute videos and many complete comprehensive cases if you want to see them all. So here we have it, before and after, before and after. You see, it just kind of like getting a haircut. It just makes it look nice and neat. It's pretty straightforward to do, and more patients than you can imagine need this procedure and want this procedure. So that's the dental minute. These techniques work, and they work every time.